Thank you all for coming, and I've just met other professional colleagues from Rutgers that I was told I had to meet, and welcome, Maria. So please call me Marty. I come to you from Utah. That is our university, and that's where I live, right with the mountains there in my back door. It's a great place, and it's a wonderful university. It is our state capital. So as Catherine said, most of my work has been in cancer control and prevention, specifically focusing on the survivorship and the end-of-life care. I'm recently moving in a little bit to some of the early detection diagnosis work, but I'm not going to discuss that today. That's essentially an R01 that's under review. So today I'm going to talk to you about survivorship followed by end-of-life. Cancership is a journey. Survivorship begins, according to the National Cancer Institute, the day you're diagnosed. And for some, it's particularly worrisome. And they don't always get, especially in breast cancer, these women don't get the information they need to move forward. You know, start as you intend to finish. So they have concerns about recurrence, and they have late emerging side effects of treatment, sometimes late emerging 5 to 10 years later as a consequence of their chemo or their surgery. And it affects families. This is our Komen race for the cure, mother and daughter with breast cancer, and a husband-father worrying about them both. And yet, they live long, they prosper, they do well, there's no higher incidence of clinical depression, and that's my friend PJ in the middle, marching as a 25-year survivor, and when this was taken now, she's close to a 30-year survivor. So breast cancer is a very survivable disease, which puts it in the realm of chronic illness, which means you do have late emerging side effects of treatment, you have physical and emotional sequelae, but it's a management issue. And I framed it as an uncertainty management issue. NIH, National Cancer Institute, recognized these about 2006 with 2 very well-published monographs stressing the importance of communication and the importance of recognizing survivorship as a distinct phase along the cancer control trajectory. So my work is the marriage of 2 disciplines. As Catherine said, I am a nurse. I grew up in the Northeast, got my degrees at UConn. I became an advanced practice nurse right here at Pace University in Manhattan. And I have dabbled in health communication my whole life. Originally, I didn't realize it was health communication. I just thought that's what nurses did. I also have 25 years at the bedside before I joined academia. So my perspective was, well, of course you communicate. But I didn't really realize there was theoretical underpinnings to this. So this is the work of Mishel, who actually happened to be my dissertation advisor a while back. And this is her theory. And then her theory was subsequently enlarged upon and adapted by the late Dale Brashears, who was also on my dissertation committee. So I have married this right from the get-go. And I understand some of you are in an uncertainty class studying Berger's work, various work, so that'll be fun to talk about later today. I really look forward to it. The variables in red are essentially the variables that I've addressed through my work, showing that we do have symptoms, whether they're late emerging side effects of treatment, they do cause uncertainty. But how you appraise that uncertainty as a danger or an opportunity is what ultimately influences coping. And credible authority, I have sort of elaborated on that, and so did Dale, to really mean communication can impact the uncertainty. What is the credibility of the information you receive? How is it delivered? How is it framed? Is it trustworthy? What source do you have? I know this is an older health comm theory, Mead and Bauer's work, but it's still one that resonates through the community today, a patient-centered approach. And I actually have an article out there on, you know, patient-centeredness, what does it mean and who decides? It's a very debatable term in terms of definition, but most of us, at least who provide bedside care, kind of think about it in conjunction with the standard definition of the care the patient wants in the manner the patient receives at the time that is appropriate for care. And I particularly still like this because there is disease. The patient does have some thoughts about it. They do have an outside life, and somehow they've got to arrive at a definition of the problem, and what the heck are we going to do about it when we go to the doctor's office? So this is a theory that still resonates with me today. The overall program of research that I have continued upon is to identify factors that influence survivorship. What impacts these women? physical, psychological, and how do they communicate their needs to those in the healthcare teams that they interact with. And then I branched into end of life, which will be the second half of this presentation, because when you look at cancer as a trajectory, you realize that there are needs. They may be different needs, but there are still high stakes, if you will, interactions at end of life, the same way there are high stakes interactions during survivorship care. And how do you frame that? So my early work and my continuing work is in breast cancer survivorship. And this was actually an earlier study I did with 203 older breast cancer survivors, because breast cancer is a disease of older women. Most women are diagnosed over 50. And I've always stratified my samples at 50 and above, because not to ignore that younger women do get breast cancer, but when they do, it's a much more aggressive disease. It is a much different treatment plan. You also have different issues. And I stratified it around 50, namely because 50 is the average age of menopause in this country. So tamoxifen, hot flashes, an older woman over 50 can probably say, oh, that's just the change. Whereas a younger woman at 42 is going to say, I don't know, what's happening to me? Very different sets of issues. Fertility is another issue that's greatly altered by treatment. So 50 seemed logical to me. Women have a lot of symptoms. Up to 78% of this sample endorsed multiple symptoms. And I've put the most prevalent ones there. Basically arm pain, numbness, sensitive skin, and fatigue. I underlined fatigue for a reason. The bothersome symptoms were not necessarily the most prevalent symptoms, which says that women have found a way to manage these concerns. Sometimes with no help from the medical community, they're finding help from their colleagues, their fellow sister survivors. Bother, the biggest one was weight gain, but fatigue was up there. And as I'll show you in later slides, they're not asking their providers for help with this. But fatigue rose to the top as not only prevalent, but exceptionally bothersome for these women. And the bother was what influenced their emotional states, their uncertainty, and exacerbated their thoughts of recurrence. And by thoughts of recurrence, I mean troublesome thoughts. It's an index by Karen Gill out of Chapel Hill, and I use it a lot. And the idea of troublesome thoughts of recurrence implies that they're episodic, that women do not go around upset all the time. They are not clinically depressed, but there are triggers. An anniversary date of treatment, hearing about somebody else's breast cancer, driving by the hospital where you got your chemo, seeing somebody who just had to buy their wig. So almost everybody endorsed episodic, troublesome thoughts of recurrence. And one of the more frequent ones was, the doctor might be wrong. These are women who are long-term survivors, as my friend PJ, 25, 30 years, and they still, the majority of the endorse this, what if the doctor's wrong? What am I going to do about this? But virtually 100% admitted at some point to thinking about recurrence. So it's a prevalent emotional need of these women fed by the uncertainty. And whether you conceptualize it as the uncertainty of the disease recurring or the uncertainty of how I'm going to live my life tomorrow, can I plan for the future, that's an academic distinction. In the woman's mind, what's going to happen to me is what she's thinking of uncertainty. But I really want to stress, none have experienced a significant emotional distress. The early breast cancer work tried to say these women are depressed, these women are anxious on, you know, the state trait anxiety scales and all these, the CESD depression scales. That's just not true. These women are active, contributing, emotionally stable members of the community who happen to have a disease that they are managing, and normally, the nurse in me says, normally, get concerned periodically. I also thought that a lot of this uncertainty was based on the communication patterns. So in this study, I looked at decision-making roles. The patient-centeredness of the interaction is a variable I've looked at, framed as unmet needs. And going back to that fatigue variable, survivors don't always tell their providers about what they need. They don't want to bother the doctor, and they're really so grateful to be alive. In some cultures, we were having a discussion about this earlier this morning, it's considered rude to sort of bite the hand that feeds you. You know, I'm very grateful to be alive. It would be rude of me to question your competence by telling you I still have symptoms. And then I also, in my postdoc, looked at the structure of the interaction. How long did they occur? When did they occur? How did they develop? What did they talk about? So in the sample of 203, I did a very quick down and dirty, it's just a continuous 5-point Likert type scale about how much does the doctor tell you and how much do you tell the doctor. Really, you know, fairly atheoretical. And I found that kind of disturbing. The doctors are driving the interaction. What's even more disturbing is the more communication you had, the more troublesome thoughts of recurrence these women experienced. So talk is making them scared. Just what I want to do as a nurse. When my goal is to calm them down, I'm making them nervous. That's not a good thing. I looked at decision making too, because I think we have an ethical responsibility, and this is something as a nurse I take very, very seriously. You want to do what's best for the patient, beneficence. You want to respect their preferences, which is autonomy, and that's woven into the definition of patient-centered care, which is now the buzzword of the decade, to say, you know, how do I best serve my patients in the manner that they decide? And then I began to think, but what if they don't want to make the decision? Because as a clinician, and both in the literature, I've had my patients say, I can't tell you how many times, what would you do? How would you handle this? And they're asking for me to put a value judgment. I can't, because my life is not their life. My religion is not their religion. My culture isn't their culture. But they're asking me for advice. And they're not asking me for advice on any particular thing. The question, what would you do, is a constellation of factors. If you were me, what would you do? And I realized that actually you can't force people to make decisions. What if they don't want to? What if they're poorly educated? And you throw in the high-stakes nature of end of life as well as breast cancer diagnoses and survivorship, and you realize they're too scared, they're not hearing. That veil we think of as clinicians, they want help. I may or may not be the person to give, but I'm certainly the person they're asking. So that is a little scary. And my personal opinion is that you get more beneficent care doing the patient some good when you ensure their choice. I do think there's a prevalent assumption in a lot of the health comm literature and a lot of the nursing literature today that says more patient activation, you all know the theory of patient activation, more participant questions, etc., facilitate better patient outcomes. I'm not sure that's true. That's an assumption. I think the better thing to do would be to respect their choice, give them the choice they desire, not encourage them to be participative if they don't want to be participative. It also facilitates the patient-provider relationship, and it builds trust. It makes you seem as if you know what you're talking about. They may not go to the internet. They're not going to talk to their grandmother next door who really has no idea what the current state of healthcare treatment is. They're going to take better advice if you can maintain that relationship. And as such, this patient-provider relationship, building trust, is a core feature in nursing and physician education today. So I took Degner's old work and looked at passive-active collaborative ways of making decisions. And I asked them, using this scale from most passive to most active with a collaborative middle ground, what did they want? So what was their preference? And then I asked them what they got. Now this was originally developed as a Coombs unfolding theory card sort technique, but many people have turned it into a continuous Likert type scale, which is how I've used it. So if you got what you wanted, there's no discrepancy, the difference score is 0. Everybody's happy. Represented by this middle ground, 48% of 203 breast cancer survivors got what they wanted. These are the people that succeeded in their patient-provider interaction. If you look at this critically, you see it's almost a perfect bell curve, and this will become important in a minute. But notice about 20% were slightly forced to be more active, about 20% were slightly forced to be more passive, and then we have outliers. Some were forced to be really active, some were forced to be really passive, and it's pretty much equal. It's almost a perfect bell curve as to how this fell out. Well, remembering that this just says how much people talk and did you get what you want, we still haven't looked at what they're actually talking about. We've been looking at the process. So what is the content and what is the structure? Which led me to another study I did, and for those of you who are unfamiliar, that is a prosthesis case, by the way, that a woman will carry her prosthesis in. So I audio taped. My previous work had been self-report. I audio taped 60 breast cancer survivors and their interactions with 6 providers, and it got me 55 usable tapes. And I did not stratify for pragmatic reasons on age 50 and above. I opened it up to all comers, but because breast cancer is predominantly a disease of older women, these still tended to be older women. The audio tapes, I first looked at that symptom of fatigue, knowing it was both bothersome and prevalent. Little over half, I found it. And I had in the consent process to tell the providers that I was looking at symptom management. I did not specifically say I was looking at fatigue. It is mild deception, not total deception here. The IRB bought it. But if I said, I want to know how you help manage fatigue in your patients, there goes my study. I've just set up my results. But I did tell them I was looking at breast cancer symptom management. And then got a whole constellation of symptoms, and sure enough, fatigue. But not very many of them, really, when you think of that it's one of the most prevalent and bothersome symptoms. I also looked at these audio tapes along some dimensions of patient-centered communication, which I've used going forward in my work, namely biomedical or physical symptom talk, contextual talk of the environment, the culture, the religion, the family, even the money, and planning. The idea in the business world of closing the loop. Who does what when? Who's responsible for the decision? I coded them using the measure of patient-centered communication, and that's a theoretically derived objective scoring system with a companion self-report measure, the patient perception. So it's what really happened versus what the patient thinks happened. And my goodness, the coding system showed these women are essentially 50% of the time getting blown off. They raise, and the way it works is the patient initiates something and you get a point if the provider responds, and you get 2 points if they really explore it in depth, and you get absolutely nothing if the provider blows you off. So it's something like, I'm so tired today. And when was your last mammogram? But I really want to tell you how tired I am today. Persistence. We'll talk about that later. When was your last mammogram? And I that these women are being blown off, and yet they are happy as clams. How can they be so happy? And it does make you think, why are we spending all this time on health communication and patient empowerment and physician skills training? If there's no problem, there's no problem. Physician thinks he did a good job, patient's happy with the result. Kind of shut down the program of research right there. So I thought that was very interesting. So I wanted to know why these women were so doggone happy. Where's the disconnect here? So I did a brief qualitative thematic analysis, and remembering that's 55 usable tapes out of 60 audio taped interactions. And I coded them into 25 independent, mutually exclusive categories, and then I collapsed them along the lines of patient-centered communication. And because when you do a secondary analysis of your own data, you look at that and you say, I got a timestamp on those digital recordings. I realized I could analyze for the amount of time also spent, which drove the statisticians nuts, but I thought it was an interesting question. And here's what we found overall. Most of the visit, as a quick digression, think about what you're paying your insurance dollars and your tax healthcare dollars for. 70% of the visit is spent in silence. For future analyses that I'll show you, we're going to exclude silence from this because nothing's going on. So the collapsed categories were essentially biomedical or symptom talk, contextual talk, planning, what's next, when do I come back to the office, do I need a lab test? Reassurance, that emerged, that's not necessarily in patient-centered communication theories, but it emerged as a very small amount, but very important, at least clinically important to me. If somebody's motivated enough to say, am I going to live? Am I okay? That's something as a nurse I can't ignore. And basic instructions. Here are just what some of the subcategories look like. So within biomedical, as you can see, it's only 14%. But when you break down further biomedical, you can see it's pretty much information exchange in pretty much equal parts. This is sort of the what they're talking about. Here's the contextual conversation. Again, not a significant portion of the visit, but some of them want to talk about employment, lifestyle, insurance. It was interesting that employment and insurance emerged as two separate categories, because I would have thought that would have gone together. But it didn't. What they were asking about in terms of employment is, I'm so tired, I can't do my job. I'm going to get fired. I'm on my feet all day. I can't do this. Or I'm a piano teacher and my arm is so sore, I can't, play the piano or conduct. So it really was the nature of the job. And the subtext here is these women are employed. They're in the community, they're living their lives, but they still have issues they have to manage. Comments also in these contextual conversations indicated that these folks knew each other. How are the kids? Did Joe lose weight? How's your tomatoes growing? Weren't you just planting them last time? Being known appears to be really important as you go forward through your cancer survivorship journey. Planning. Very mild part of the visit, but one that is so often ignored. This is the business model of, okay, do you order my lab test or do I? Who gives the results? Who schedules my mammogram? How do I get the results of my ultrasound? So close the model, and that's actually a component of the R01 that I have under review, is this idea of, it's very small, but it's very important. Because a lot of, especially older women, will fuss, well, the doctor will call me if he needs me. And 4 months will go by and there was no ultrasound done, and the physician thinks the woman's going to do it, and the woman thinks the physician's going to do it. Reassurance, I couldn't ignore it. It's only 2% of the visit. When it does occur, it's driven by the patient. Occasionally, it's offered by the provider. I suspect it's offered on the basis of nonverbal communication. Because remember, these are audio tapes. These are not videotapes. So what I concluded is not all of these dimensions are as important to women as others. In other words, they're weighted. So to think reassurance is important as symptoms, no. You got 15 minutes with your provider, you're going to talk about your symptoms. Now, I put this chart up. This is the time analysis. As nurses, and you will see advanced practice nurses, which I also am, and PAs and physicians, we're all taught about how to structure a visit. What do you do when somebody comes into your office? And typically, we all have an agenda, right, as providers. I mean, this is the flip side. This is my side now as a nurse, not the humanistic side as a patient. I got 15 minutes. I've got to, before the physical exam, figure out why you're here. So I'm always taught, do my assessment, ask my questions. What's your problem today? Anything else? Okay, good. Take off your clothes. I'll examine you. I'll be back. And then wrap up. Okay, your exam showed this. Here's the tests we're going to order. Have a good day. And I don't mean that to be callous, but I think it's really important because I do think providers have a routine. When a patient comes in and disrupts the fruit basket, does a different routine, it doesn't go so well. The provider doesn't know how to do. You've broken their stride. You've broken their train of thought. But look, symptoms, exploring illness, every single visit. It makes sense. The majority comes during the physical exam. Oh, you found the spot, it hurts. Oh, and let me tell you, my arm doesn't bend so well. The contextual, whoops, that's not what I wanted to do. How's the family today? Again, they're making small talk. I suspect this is a modesty issue. When somebody is examining you to kind of get your mind off it, you are making some small talk. But look, every single dimension in every single portion of the visit. If I were writing this out as a student nurse 35 years ago, I would have said all the red on the left, all the turquoise on the right. The planning. Now, most of the planning, when do you come back, occurs at the end. That makes sense. The turquoise line's bigger, but it starts right up even before the physical exam. What are you here for today? As a clinician, that also, in a way, made sense. What are you here for today? Oh, I need my mammogram. I need my blood drawn. Okay, but that is planning. So would they set up the blood draw, the test, the x-ray, the referral immediately? Look where reassurance comes, the green line, right in the middle of the physical exam, and that too resonates with me clinically. So does that lump mean anything? Do you think I should be worried? Resonates, but if you're going to deliver patient-centered care, you can't come in with the way medical and nursing education is taught and say, I have a schedule. Schedule just got blown. Every dimension, every part of the visit. So what influences patient-centeredness? Being known facilitates the patient's perception. And, you know, there's something in me that says whatever the patient says goes. It's like in business, the customer's always right. So being known really seems to influence the patient's perception. And the ability that they'll also maintain their interaction with the healthcare system and come back for their future care and surveillance. This thing is jumping. So I actually, because we do a lot of planning with these people, I asked the women how much of a plan they had. I didn't intervene. This was merely descriptive. But did you have any specific goals, any specific plans? What did you want to accomplish today? And what I found was the more specificity of these women, when the women had an agenda, they actually had lower perceptions of the patient-centeredness of the visit. And I think we do a lot of blaming the provider. This is a case where I say, you know, as a clinician who's done these visits, it may be hard to meet your expectations if you've got such high expectations for your visit. Under managed care, etc., I only have 15, 20 minutes. So from the provider perspective, so maybe we need to train our patients to say 3 big issues. How much time do I have? What's a realistic amount of information I can cover? This one bothered me because you want to think you've met the needs of your women. And clearly, if she has a real itemized agenda, we're not meeting her needs very well, and nor does she think so. Everybody also looks at the provider factors. You know, do women deal with women better? Do older doctors have more experience, the Marcus Welby effect, you know, versus the younger doctors? And they didn't have any effect. The provider factors just have never held up in any of my work for influencing perceptions of patient-centeredness. So my breast cancer work suggests that visits are under an hour. Patients spend a lot of time by themselves. You have to think about health systems and organizational things. And the symptoms that are discussed, while they represent the bulk of the communication, certainly not all, but the bulk, they're talking about primary care, if you read those list of symptoms. They're not necessarily talking about oncology-related concerns. So again, you have to think of it from a systems perspective to say, should these women still be taking the time of an oncologist, a higher paid specialist, you know, 25 to 30 years into their health care, or could it better be managed by primary care? And these are primary care, but the thing is, primary care people don't know a lot about how treatment impacts cancer care. And in fact, there's an R01 and a big education initiative out right now to educate primary practice physicians about cancer care. And knowing breast cancer is a disease of older women, that's just the comorbids. You could see in anybody. These are normal women that just happen to have had previous cancer. As survivorship length increased, these types of oncology-focused discussions lessened, and it was all moderated by the ability, the perception of patient-centeredness was moderated by the ability to ask questions. Of all the factors I looked at, if a woman could ask questions, she felt the visit was more about her. And as we've emphasized, not confined to any one section of the visit. Dimensions are weighted. A woman may not be as interested depending upon her daily events. Symptoms may be it, or she may be worried about losing her job. So they're weighted differently, and being known is very important. I mentioned before I thought some of the reassurance was driven by nonverbal. Remembering that these were audio tapes, and I know as a provider I have hugged my patients. I have patted their knees, and that's when the shoulders come down and the tension comes down. So I was missing a big component of the communication interaction in these studies. Nevertheless, it was the best I could do at the time. Pragmatic consideration always affects your research. I briefly wondered, yes, did you have a question? Oh, I just was wondering then about patients that don't have cancer. Do they have the same amount of unmet needs, interaction, same impression of patient-centeredness? So I took a wander into family practice. And I videotaped 188 primary care interactions. It was first come, it just couldn't, the inclusion criteria was routinely scheduled. I didn't take any emergency type visit, sudden. So it was people that were previously on the books because I wanted to kind of take the high stakes out of it and let the relationship emerge as opposed to the diagnosis emerge. And 188 tapes got me 174 usable tapes. Every now and then, you know, the system would stop. And I used the 4 habits and the MPCC again because I built in a validation study. The 4 habits is out of Kaiser, and it was still trying to see how the provider responds, beginning, middle, and how they conduct a visit. So I wanted to see if these 2 studies, both purporting to measure patient-centeredness, gave me the same answer. And the Cliff Note version is essentially they did. This is the setup. I would emphasize that this is not the doc. This is just a white sweater, the patient. You can see she has a walker and she's heavy. And so this is the physician, and this is a nurse that's assisting her at this particular moment. The cameras were actually set up. You can see the ceiling mount, and it worked very well because these are actually used in the medical residency training. So it was easy for me to go down and use this. It's harder for me to put a tripod up in a cancer institute. You don't get as good quality. The patients were 18 to 89, as is typical demographic breakdown in this country, 2/3 women. The providers were everything from right out of school, first job, to seasoned. This is an academic institution, so seasoned full professor attendings at the University of Utah. And there was a mix. As you can see, the gender of the providers more or less mirrored the gender of the patients, although there was no attempt at matching. This was first come, first serve. This really struck me. When you go back and look, that discrepancy, what did you want versus what you got, on decision making, 86% of family practice patients were able to get what they wanted. Only 10% were not, and there's a little bit of missing data. That's the difference in the math. These were self-reported. That's really different than my breast cancer survivors, as you remember that bell curve, where half got what they wanted and the other half were not, and they were evenly split between being more passive and more active, that perfect bell-shaped curve we talked about. So very different when I compared results on the same instrument. Using the coding systems, the visits both for breast cancer and family practice coded out at about 58% patient-centered. So family practice patients are being blown off just as much as breast cancer patients in getting their needs met. Provider variables, again, had nothing to do with it. Age, gender, experience of the provider. The difference in these groups was the ability to achieve their desired decision-making role. Again, I thought it would be interesting to see the characteristics of those that were unsuccessful. So I did a sub-analysis. You know, what went wrong with this small group of patients? 10%, remember the were half more active, half more passive in the breast cancer? The family practice became a little more in your face. If you couldn't get what you wanted, they got more active. They assumed more responsibility, which I thought was interesting. And I have done a lot of primary care. I'm actually a family nurse practitioner, and that made sense. So if I said to a mother, brought a kid in with an earache, oh, I don't know, I think I'd really like to just go test his hearing, she might say to me, no way, just give me the amoxicillin. Let me out of here. I know what works for my kid. So it wasn't surprising to me that family practice became more active. And think about the stakes, if you will. Cancer is a high stakes visit. Family practice, not so much. So, the type of medical practice may actually influence the ability to achieve your desired decision-making role. And once again, it was associated, a stronger patient perception of patient-centeredness was associated with the ability to ask questions in both populations. So I began to think about end of life. And what happens here at end of life? It's high stakes. There's decisions to be made. Very upsetting if you don't get what you want at end of life. And I had an opportunity to join a PO1. The PO1, I'll explain that in a minute, was addressing caregivers, not so much the patient. There's been a lot of research on the patient, but the literature is robust, saying that the health of the caregiver mirrors the health of the patient. And remember, these are older people. They have the same comorbids, heart disease, diabetes. They may have cancer themselves. So these were all cancer patients at end of life that this PO1 is focusing on. And Another so what is it may affect bereavement. We looked and did home hospice as opposed to institutional hospice because, again, decision-making, patient turf, and there's a long-standing relationship between a hospice nurse case manager and the family. So it really gets into family and relationship-centered care. And yet, because it's in the home environment, not in the clinical office, it's not as amenable to residency training, inpatient, where we have all the power, you know, home is kind of sacrosanct, so we don't really know how this unfolds. So we did a little pilot, as you always have to, for NCI-funded studies. And that is the chest of one of our colleagues. And she, as she said, her chest is getting a lot of mileage. So we took her head off for HIPAA and privacy reasons. And she did tell me I was free to adjust the picture to make her appear as alluring or not so as I wished. So, Photoshop. No, I didn't touch it, actually. That's all her. But what we did is we hung tape recorders around hospice nurse necks. And part of this was feasibility. Could we even get good audio recordings? Obviously, you're not going to set up a camera. Although, believe it or not, the nurses and the patients all wanted us to set up cameras in their home. But when you're working in the community, you have to have buy-in. And these hospice nurses are home hospice, so they're going patient to patient to patient in their car. And even though they suggested it, the pragmatic researcher inside of us said, oh yeah, they're not going to tape if they have to set up a camera every time. We're not going to have any data. So we settled with audio recorders. The patients were required to be over 60. The spouse partner had to be the primary caregiver, so we didn't take adult children at this point because we wanted the bereavement, the long-term family relationships. And we worked with 7 caregiver nurse dyads, 5 nurses, and the patients all had end-stage cancer. Some of the characteristics, you can see the caregivers are predominantly female, predominantly younger than the patients. They've been in committed relationships for some length of time, very long to relatively new. The nurses, we had 5 nurses for 7 cases, so that meant 2 of our nurses were working with 2 of our caregiver patients. And they're 100% female, they're 100% Caucasian, and they're experienced nurses. They had been a nurse before, they were a hospice nurse, so RN registered nurse and hospice RN is what HRN means. So they entered nursing first, they sort of found a calling as they describe it, and they go into hospice care. We audio taped 32 visits over these 7 dyads, and now this is important, you're going to laugh later. Notice that we had 2 to 11. Range was the visits. So they're admitted to hospice, we audio tape up to 11 times, and the patient died, and the study is over. These visits, unlike the clinic and other visits, lasted close to an hour. There was a lot of talk, over 1,000 statements per visit. The patient is participating, but our focus is not on the patient. And here's the first clue of audio taping gone wrong. 56% had multiple family caregivers involved. When you're listening to an audio tape, how do you sort out all the voices? Should have been our first clue. But it wasn't. We adapted the RIAS rotor interactional analysis system substantially for the home environment, and we stratified these based on the National Consensus Project for Quality Hospice Care, the domains of care essentially that are considered to be present if you are providing optimum hospice care. And here's what they look like. There's a structure, and I've given exemplars. You can read this for yourself, and I'm happy to send these to anybody who wishes them. We won't go over these in the interest of time, but you can see that there are process, symptoms, psych, social, how do I tell the kids, spiritual, what happens when I die, regardless of what faith you belong to, and then the process of dying. What's going to happen? How many people have actually seen the physical dying process? There's a lot of questions, and those questions are very different than actual symptom questions because it's the process of actively dying. And this is how it panned out in the pilot. Psych, physical, symptoms. What does this mean? Is he getting worse? Is it now? Is it the time? And a little bit of social. How am I going to tell the kids? What should I tell the neighbors? When do I go back to work? These kinds of things. And our pilot worked essentially fabulously. We demonstrated that A, we could recruit home hospice patients, which people tell you you can't, and that we can actually get good quality audio recordings, hanging a recorder around their neck. It doesn't, you know, you don't get the swishing back and forth on the code, or they don't forget, or they don't leave it in the car. So we demonstrated we could do it, and that the RIAS worked. We also involve our doctoral students, pre and postdocs, in this. And we have a synchronous distance education program live, but via Skype. Hi, Marie. So, Maria. And used a secure upload and download system, and the IRB bought it with HIPAA compromise. So it says that we can involve our students living across the country in our coding process, which is a fabulous opportunity for them. So here's the major study. This led to a PO1. Dr. Kathy Mooney is a friend of Dr. Susie Beck's, and I feel very privileged actually to be on this study. At the time this was launched, I was the only assistant professor. I'm not assistant now, but I was at the time. They let me play with the big people. And I will emphasize for the students in the room, sometimes you have to take opportunity as it comes. End of life wasn't really my thing, but as the study evolved, I realized it was literally just another phase in the cancer control trajectory, and you learn a lot about methods. So there is some advantage to being flexible and allowing your research to emerge as opposed to being dogmatic. This was an opportunity, and I took it. The only point of this slide is to show you that there are 3 projects. This is a PO1. So the general mechanism instead of an RO1, a parent grant, is that it's 3 studies and a core, and we maximize resources because we recruit 1 patient population that then can use data for all 3 studies, and we can look at a process. So in this case, we are looking at the caregiver from admission to hospice into 6 months to a year bereavement. You know, studies have looked at these processes in isolation, but does that really reflect the experience of the caregiver? So this is the benefit of a PO1, and the only other reason I put this up here is to notice that it is an interdisciplinary team. We have nurses, we have sociologists, we have statisticians. In the communication project, which I'll explain, Lee Ellington is a clinical psychologist. So we have an interdisciplinary team. This is the general theoretical model. TLC stands for telephone linked care. This is where the caregiver at home telephones the symptoms into the hospice nurse. So it's a symptom management, remote symptom management program. DPM stands for the dual process model, and it's our gerontologists, and they are focusing after death of the patient. Remembering this is all about the caregiver. They're focusing after death of the patient on the bereavement experience. And we've conceptualized communication, nurse-caregiver communication, as the mediator that improves symptom management of both the caregiver and the patient, and ultimately may influence bereavement. So we are in the middle of data collection. We do not have results that I'm going to show you, but that's the theoretical approach. The communication is the linchpin holding symptom management and bereavement together. Longitudinal descriptive, and we intend to enroll about 300 spouse partner caregivers and 21 nurses. Be prepared to laugh. 21 nurses. The benefits is, again, lower subject burden, greater use of NIH, National Cancer Institute dollars, because we're using the same subject pool. We have a core that manages the same instruments. So it's just a good way to look at a process. I'm going to speak directly to the Nurse Caregiver Communication Project. We call it NCC, that Lee and I and Maya are looking at. And again, we hope to be able to explain the mechanisms. A lot of the analysis uses hierarchical linear modeling, and we hope to explain the mechanisms of how communication impacts symptom experience for the caregiver and bereavement experience for the caregiver. We are blocking using those domains of care. We have a lot of tapes. And so we're simply chunking them out. This is a pre-doc research immersion practicum. They chunk it out. This allows us to tell us sort of how much, like I did in one of the earlier breast cancer studies, how much talk is devoted to symptoms, to spiritual, to existential type things. And we've adapted the RIAS heavily. It was originally developed for use in the clinics, but we're not in the clinics, we're in the home. So a lot of the how did the front desk person greet you codes just don't quite work. And yet, how do you code, oh, I want to tell you about my Christmas tree decorations. That's important, that's being known. So we reduced, also pragmatic, we can't afford to pay coders to code every tape, from 41 to 13, and we broadened them based on the home care setting to include things like small talk related to lifestyle, Christmas decorations, etc. And we're using the Noldus Observer, which now has the RIAS on it. Okay, careful what you wish for. I also point out that while a lot of people say hospice research is difficult, end-of-life research is difficult, it's not difficult, it just takes diligence. So we have screened 1,800 patients. You can see almost half is not eligible, meaning they had a quick death, meaning they weren't cancer diagnoses. This is still cancer at end of life. We've managed to contact about half of them. This is pending. This doesn't mean they refused. This just means we haven't got a hold of them yet, or they just, like, this is as of yesterday, so that we just got the name. Yeah. They just got admitted to hospice. 203 are interested in any of the 3 projects. That was a PO1 study-wide decision we had to make. We were losing recruitment by requiring them to be in all 3. So we are letting them participate if they wish in any portion. So the enrollment numbers across studies will now vary. That was not our intention. 300 turned us down. 28th patient died too quickly to even let us get consented. And we have successfully enrolled 166, and these are patients, these 37. We haven't lost them. We just have like a visit scheduled. We're going to go out this week. We just got their name. So really, on our 300 that we're aiming for, and we're about halfway through, we're right there. We're right there. Well, what happened? Remember those 21 nurses that we had budgeted for to the National Cancer Institute in time? We expanded this. These hospices are in Salt Lake. We're working in Greater Boston, and we're working in Chicago. And every nurse wants to play ball. We have 123 nurses, not 21. There went the budget. So, okay, remember we said those 11 visits on average, that was the high side? You want to say, die already. We have up to 60 visits with some of these people. The mean and the median is still about that. You know, we had 2 to 11 in the other. So we're still right there in terms of average, but this is what power gets you, students. Your results change a little bit. So most of our visits, you know, 8, we have some with 20, but for 25 cases, we have this 1-2 cases down here. My personal thought is these are for a qualitative analysis, and these are available if anybody wants to use them for dissertation type work, is that these are going to be the more interesting ones because the conversation is really going to evolve beyond the process of dying. But in the meantime, it is a coding nightmare, and it is a budgeting nightmare. So we had to make some tough decisions. We train our coders for 6 weeks. We're trying to maintain a kappa of greater than 0.6, and 20% are double coded. But we had to make some tough decisions because we have too many tapes and we don't have enough coders, and some of them are students, and we still want to maintain our kappa, so we want to do it well. So we wait till the patient has now died 40 days. That ensures that the tapes we code are going to be tapes representing dyads that are enrolled in all 3 studies. We want to, and there's a 2-week bereavement death, and then our gerontologists study them and sort of reconsent them, even though they considered originally we reconsent them into the bereavement thing. So we want to make sure that if we're going to have to not code some tapes, the ones that we do code are at least across all studies. So we have comparative measures from a development measurement perspective. We code the first tape, the first visit, then we code the very last tape prior to death. Then we code the median. If we have time and the backlog of tapes to be coded is reasonable, then we code a midpoint between the first and the middle, and we code a midpoint between the middle and the last. So obviously we're not, I mean, you know, 300 tapes, maybe 11 visits. Oh, we have so many tapes. Last count, I believe we had 1,800 tapes. Our nurses want to play. We've got engagement. So what does this all suggest putting together? That cancer communication research is important. It optimizes interactions along the whole spectrum of the cancer continuum. And it ensures needs, regardless of whether you're an end-of-life patient, a breast cancer patient, a family practice patient, better communication research ensures patient needs are met. And to do this, we all have to work together to improve education and practice, learning together, kind of one of the reasons I think I'm here today. Ultimately, then, we improve patient-centered care, patient outcomes, systems outcomes, wellness and prevention outcomes. And it's really important because we all see things through our own lens. We all bring something to the research team. Every voice is important. Every perspective is valid. And it's fun. It's fun to work together. So, I will open the floor for questions and comments. I'd love to hear input from some of the different specialties in the group.
Maria, in case you have one
yes, ma'am.
question.
So I really enjoyed your talk.
Thank
but
you.
I'm from different field. So I also study this kind of a communication, but more from design perspective. And so that's why I'm very interested in kind of like nonverbal things, right? So one of my colleagues in University of Washington studied, also followed the breast cancer patient, go to their clinics, and then before they ask them, after they ask them, right? So that group actually find out when the patient describe their feelings and they're not like satisfied in terms of communication and everything, they mention a lot of nonverbal cues. For instance, how you design a room, right? How you design the clinical room, and then how the doctor's body language that probably really cannot really reflect from your audio kind of.
No,
right?
it can't. Although we do have, I did look at environmental factors. It didn't really emerge, but I did subcode, is the room too hot? Is the room too cold? How long a wait? It was the length of wait that annoyed people the most. So there are certainly system factors that were not explored in these data.
That's why I was thinking about how we can actually, work together to really understand whether that is factor at all. But you mentioned those kind of environmental kind of design of even the examination of the bed, and the patient really mentioned about that. And so from her study, we more care kind of like understanding how the design really matters in the first place before even the conversation started.
Yeah.
And then so that's something I was.
Well, and I don't know if you recall from the family practice slide I put up of the actual screenshot, but if you noticed, there was the patient, then there was the computer, then there was the physician. So one of my colleagues is doing a secondary analysis of those data to see sort of with eye gaze, although you can't really capture that, but is patient-centeredness sort of derived by how much time the provider spends gazing at the computer screen with electronic health records?
And also how you actually place that screen.
Exactly.
Actually, sometimes patients, when you place
They turn their back to you.
Yeah.
Yeah.
Sometimes the position really also matters.
Exactly. I couldn't agree with you more.
Yeah.
Exactly right.
Yeah, that's the kind of thing.
But I think when you start looking at communication, there are so many factors that could influence it, just so many factors. So we've teased these out in separate studies, and sometime we're going to have to pull this all together, and lump it back into just a global, do you like it here, patient type study. I think that'll be a hard one to get funded because addressing a global perspective is different than addressing the individual factors that perception. Sure.
I also noticed that the content of communication, right? A lot to do the lab test and all those factual kind of data communication. So one of my study right now is really just push to design information system for patients to use, and for all of those factual things, maybe we can communicate it pretty well before they go to see the doctors. So during they are interviewing with the doctors, they can mention more important.
So an activated, prepared patient.
Yes.
That is part of the focus of the R01 I have under review.
Yeah.
Yes, ma'am.
Could you share a little bit more of sort of the process that went into selecting your coders even before you put them into the training program? I was very interested in reading about that, how when you have a sensitive, emotional topic, that who ends up being your coder and sort of
so
the breaks they get or the briefing that they need becomes a very integral part related to reliability and validity.
So you bring up an excellent point, just an excellent point. Initially, we selected our coders based on the research needs of our students. So if I have pre-docs interested in communication type events and need a research practicum, we offer them academic credit with the stipulation that they had to stay for a year because we don't want to keep training. And they really get, a team of coders becomes a team. With consensus coding, we go over these 20%, we hash out the issues, and they become a very reliable unit after time, and it just continues to improve. So we didn't want them coming and going. With the volume of tapes we have, we expanded this, and I've actually hired a couple paid positions, full-time paid positions. And we've had to reduce our own FTE on the grant because of that. But it's really important to maintaining our coders. We actually offered a lot of this to nursing students, but because our master's and undergraduate level nursing students are involved in clinical experiences as part of their education, especially the more senior students, they don't have the time. So we opened it into the psychology students who actually understand the emotion and the anxiety, and they seem to have more time. So the majority of our coders are either health communication students from the communications department at Utah or psychology students, and one or two paid sort of senior, almost coder managers at this point. The unintended consequence, which you alluded to, is what happens when you listen to these tapes over and over and over. And we have a substantial percentage of tapes where the actual death is caught. That is serendipitous. We didn't think we'd get so much, but you hear the death rattle. You hear the sobbing. You hear the patient cry out. So we've caught several of these. And the problem with not using nursing students, at least using psych and health comm people, is unless you've had death in your own family or some other kind of sensitive issue background, our coders were becoming devastated. And so we have initiated regular monthly briefings and coder meetings, and we specifically, as Lee is the principal investigator, I'm a co-investigator, we step out of that room. We actually have brought in a social worker that works in the bereavement project actually, but she is a social worker and she runs our Hope and Caring and Grief program, which is a 30-year community service out of the College of Nursing, death, dying, and bereavement type community support counseling. And she, as a neutral specialist, actually talks with our coders. And none of them have quit. And the reliability hasn't suffered. But, you know, I went to a sermon once that said, who ministers to the minister? And we realized, you know, who helps the coders as they hear this. So we've helped them keep it in perspective, but it was an unintended consequence for sure. Good question. Yes, ma'am.
Hi, my name is Nicolette. I'm actually a recent graduate from Rutgers with a BS in public health.
Congratulations.
Thank you. And I have a budding interest in patients and healers in the context of culture. And I'm just curious as to your experiences as a nurse. What have you seen with cross-cultural health issues and dealing with alternative medicine or even language barriers, and how patients express the symptoms that they're having, and what you've seen in practice helps overcome those issues?
That's a great question. Very perceptive. You're going to go a long way. I can answer that from a couple experiences. The nurse in me says cultural competency is always important. You must put yourself in the position of your patient as best you can, knowing that I am a Caucasian middle-aged woman. I am not a young Latino teenage male, you know, so within the realms of ridiculousness. I was talking about this with Shauna earlier today. I was a very effective African-American recruiter for a breast cancer study in North Carolina, and we over-recruited based on the state demographics. So we got more black women in the study, and we were very proud of that. One of the things I had to learn on that, in terms of your question and the influence of culture, is in a Southeast Baptist religion, where most of my women were, I was trying to enroll them in a self-help intervention. I needed to reframe it, not to be trite, but in a frame of the Lord helps those who help themselves, because I was in the position of challenging their faith. If I said, let us help you, our intervention will make life better. Oh no, the Lord makes my life better. So I didn't want to challenge their faith. So that was one instance where understanding, as soon as I said you're working in a partnership, and I never could use the term your cancer. These women would say, it's not my cancer. I don't own this disease. I gave it over to God. So as soon as I was able to say your diagnoses or your breast cancer disease, but the more I could take the pronouns out of it, you know, the disease instead of your disease, I had better interaction. In Utah, it's a very conservative Latter-day Saint, Mormon population. So you have to also keep in mind conservatism, modesty, and the role of protective garments. This culture wears a t-shirt and a pair of panties, shorts, that they believe the Lord, they're protective. And as long as they have their garments on, they're protected. So if they get breast cancer, what happened? Why didn't the garment work? So there's a loss of faith there too, which is very profound. Now, as far as alternative medicine, Utah also has a lot of First Nation, Native American, Navajo primarily, and very, very rural in Utah. I mean, really rural. A lot of injuries and burns and trailer fires and farm accidents and all sorts of things. And we have to help support the medicine of the tribal elder. When someone is dying, you put the head facing north. Sometimes we flip the beds in the hospital room. The head should face north. Very important. That is how the spirit will find you when you pass. If your feet are north, the spirit doesn't know how to find you. So little things like this. Alternative medicine, that's a pure communication thing, and I'll just put my clinical hat on and say, I always ask my patients to tell me the truth. Just tell me what you're doing, then I can make sure you're not going to become a chemical experiment in your own body. You know, as long as I know, I can deal with the side effects. If I don't know, I can't help. And some of my patients used to go to prayer revival meetings and all sorts of salves and stuff, as long as it does no harm. You know, the placebo effect is a real thing from a medical perspective. If you have faith that what you're doing helps, it often helps. So I never disrespect Oriental medicine, and I do think some of the various therapies, Tai Chi, acupuncture, yoga, have definite proven benefits. But there's a lot we don't know in this world, so it would be very arrogant to dismiss one First Nation or Eastern medicine and say, oh, Western medicine is correct. My way is the right way. My religion isn't your religion, but do it my way, you know? We fight wars on that in this planet. So I do step back and try and look through the lens of the patient, what's important to them, and how can we meet their needs. And some of that is as simple as E.F. Hutton. You ask. That old commercial, how did we know? We asked. I'm not afraid to say, I don't understand Navajo custom. Please tell me how I can help you. I'm not LDS. Please help me understand the meaning of your garments. I know they're important. So I ask. People will tell you if you're genuine. Long answer to an easy question, sorry. Yes, ma'am.
So I've been thinking about this idea of patient empowerment.
Uh-huh.
And I was wondering how that looks like throughout your research, especially when you're talking about maintaining the balance between beneficence and autonomy, and how do you balance, the role of being a self-advocate versus possibly the physician advocating for you to do a certain thing. How does empowerment come into play?
I think empowerment's important. But I think actually culture in and of itself and consumerism focus of medicine is breaking down that barrier. Journalistic, Marcus Welby, MD, Father Knows Best. So I think that's going away. I think we've done a good job with PSAs and various educational materials to say, patient, you have a voice. So I think the community gets that. How to exercise that voice is a different question. And that's where I think it pays when you're meeting somebody for the first time, say, I just got to meet you. How do you like to make your decisions? Are you a nurse? Do you have a background here? Do you have any strong opinions? How would you like this to proceed? So I ask, and then I give them what they want. I do think that we have spent a lot of time blaming the provider for this. And as a provider, just in spirit of full disclosure, frankly, there's a part of me that resents that, because I am for my patients. I do want the best. And we all know perfectly lovely healthcare providers that you trust your life to. So I think while some providers can be brusque, and we should definitely still include communication as a competency of education and track it and teach it, and that's why the cameras are up in that residency program. It's not just diagnostics, it's relationship type and nonverbal type. I think empowering the patient is also important, and if the patient, as we saw in some of these slides, has unrealistic goals, rather than blaming the provider and saying it's not a patient-centered interaction because I couldn't spend 2 hours with you, teach the patient to say, in 20 minutes, maybe 3 concerns. Let's hit your top one first. Why is that important to you? How's it impacting your life? Help the patient to understand some of the limits of the healthcare system. And as healthcare reform comes in and more patients are entering an already stressed provider delivery system, I think providers have to get, let's cut to the chase, which may seem rude, and patients have to get at, okay, this is that I really need solved today. If we have time for others, great. So I think there's room for skill training on both. I do think we have to start to work on the patient, not the provider. I think the providers are trying. I don't know where we are for time, so.
How about we're wrapping up with the, do you want to let Maria?
That's all right.
So you're saying that patients are coming in with a list of maybe itemized concerns. What is the nature of this visit? Is this routine? So they're coming in because they come in every 6 months, or are they coming in because they have a problem?
So the question is relating to the list of concerns. Patient comes in on routine visits. Are they itemized? They tend to be concern of the day, and the priority of the concern to the patient may change. But it's usually in terms of at least breast cancer and sometimes prostate cancer, late emerging side effects of treatment. And, you know, I've seen a chest disintegrate 20 years later from radiation and massive hemorrhage and things because of massive amounts of radiation, cardiotoxicity from adriamycin, etc. So patients don't always they don't know how to interpret their symptoms. Does my symptom means my cancer's coming back? Or does it mean my arthritis is getting me? Is my bone pain because I have metastases to bony mets? Or are my knees just aching? So a lot of the symptoms are routine primary care overlaid with the fear or the uncertainty about recurrence. Does that answer your question, Maria? So why do they go that day? I screened for routinely scheduled visits. Visits every 3 months, every 6 months, whatever you were told in the planning stage of your last visit. When's your next appointment? I did not take emergent care in any of my visits because that is a high stakes visit with a very focused question. I wanted to see from a communication perspective how it unfolded. You're welcome.